morning, everybody. Next 20 minutes, we are going to discuss a little bit of surgical airway emergencies. It's not a familiar topic. If you are dealing with tracheostomy and airway setups, head and neck surgeries, you will face different sequences of difficult airways. Okay. The objectives, what we are going to discuss for the next 20 minutes is recognition of tracheostomy complications and post-operative neck hematomas commonly occurs following neck surgery, and also the situation require immediate actions due to emergencies like angioedema and need for going for surgical emergency brachydectomies or needed brachydectomies. So this is a common scenario, case study. Then we'll have two cases. First one is this: 65 years old, male underwent left carotid endarterectomy. 2 hours later, suddenly he drops the blood pressure. Systole is around 50 and respiratory is tachypnea around 32, and saturation drops to 80. So in this patient, the airway is compromised and there's evidence of stridor, so it's obstructing the upper airway, and breathing is abnormal, definitely. Tachypnea rate is around 80, and his oxygen saturation also drops, and there is hemodynamic status also depraved due to loss of systolic blood pressure. That means sudden drop. So you obviously know it's something going on, and there's an obvious finding is a hematoma. So it's due to bleeding and it's due to airway compromise. So how we are going to manage this patient will come out later. So what is happening and what should be done, I'll discuss it later. Okay. So common in ICU setup, 20% of incidents are due to airway issues. That means during intubation, during extubation, or during treatment, there may be airway issues. It's a common problem in ICUs, and it's an indication for ICU quality of care also. So we always focus on airway issues while managing post-operative surgical patients, while on ventilator support or there's a head and neck surgery, there's high risk of airway incidents. And we all should need to identify emergency because it's airway. If you lose the airway, patient will die. So first common complications of tracheostomy is loss of airway. Usually common complication of following tracheostomy is tube dislodgement. So usually after putting tracheostomy tube, it will take 7 to 10 days to create a stroma, permanent stroma. Unless if it is dislodged before that, you will end up in problem to putting the tube in again. So usually for surgical tracheostomy, you will be safe after 5 to 7 days, but percutaneous tracheostomy is not safe until 7 days if it is dislodged. So if it is more than 7 days, if the tube is dislodged, I think you can put the tube back again. But if it's less than 7 days, there will be much difficulty in putting tube in. Better you have to go for endotracheal intubation using laryngoscope, or you can have a back mask ventilation until you get the expert opinion. And after that, surgeon can come and put a tracheostomy tube in. So I will advise if it is more than 7 days, you can try a tracheostomy tube insertion again. But if it is less than 7 days, you have to go for endotracheal intubation through mouth, or keep mask ventilation and get a surgical opinion to put the tracheostomy tube in. So how to avoid tracheostomy tube dislodgement? First thing, keep the tracheostomy ties tight. Whenever you are tying the tracheostomy, put one finger below the tie and then it will loose, otherwise it will obstruct the venous rectum. usually allow one finger below the thighs and the thigh, and remove the traction which occurs through the ventilator tubes, and better to keep it in the tracheostomy tube in the center position. Otherwise, it will pull the tube out. It's common incidence, commonly occurs in ICU. And while on tracheostomy, minimize the patient transport and better keep patients sedated or comfortable and avoid unnecessary or excessive cough will cause tracheostomy dysfunction. So second common complication following tracheostomy is tracheostomy tube block. Mucus plugging occurs in the tracheostomy. So usually if you put double lumen tube, you can remove the inner tube and clean it and put it back. In our setup we are using single lumen tubes. So there may be mucus obstruction. Better option, put a suction tube in, suck it out. And if you have doubt, if it's going in, secretion suck out, it's nauseous, sort it out. If you are facing difficulty in putting the tube in, it may be a partial obstruction or tracheostomy tube dislodged to a false lumen. In that case, what the recommendation is, put the ETCO2 adapter and see whether capnography is there. If this capnogram is there, ETCO2 is there, tube is in, then you can put the suction tube in and suck it out. Or if there's absence of capnography, this tube is dislodged. Better take out the tube and go for endotracheal tube to mount and ventilate, or remove the tube and face mask ventilation, or remove the car, release the car and do a face mask ventilation, we maintain the airway. If it is completely occluded, go for tracheostomy tube change after 7 days. Otherwise, go for endotracheal intubation to mount. You can go ahead with the surgeon's opinion for maintaining tracheostomy. So, third common complication following tracheostomy is bleeding. So, one thing commonly occurs, tracheoinnominate artery fistula. If it is prolonged tracheostomy tube, usually it occurs 3 to 4 weeks later on. Due to continuous irritation of the lateral wall, anterior wall, it will erode the tracheoinnominate artery, which occurs in 0.7% of tracheostomy population. So it will cause massive hemorrhage, it will obstruct the airway, and it will cause bleeding. Usually mortality is around 100% if you haven't identified the early detection of tracheoinnominate fistula. Management, call the surgeon immediately, inflate the cuff over pressure, will create a tamponade effect and control the bleeding, and go for intubation through oropharyngeal, maintain the airway and the ET-tube through mouth, and maintain the oxygenation. After intubation, you can maintain the pressure by fingers until surgeon arrives. And other complication is the stroma bleeding. Is common, it self-settles spontaneously. With the pressure, the secretary moves on and keep the cuff to prevent aspiration. So tracheoinnominate artery fistula risk factors, usually high cuff pressure because mucosal necrosis and ulceration which leads to bleeding, and improper placement of cannula tip. That means due to ventilator tube play or malposition tracheostomy, will erode the wall and cause the bleeding. Or if you extend the hyperextended neck, it will cause pressure on the trachea, it will cause the bleeding. And other causes like radiotherapy neck and pyelosteroids for long term will cause erosion and bleeding. So post-operative neck hematomas are commonly like aortic endarterectomy, endocrine surgeries like aortic anaesthetist thyroidectomies, and laryngectomy, tracheostomy, and neck trauma. Usually one of the common complications following carotid endarterectomy. 2%, 1.4% of the population will develop neck hematoma. For all the next surgery, you have to monitor the patients and you have to look for any hematoma. Majority of the hematomas won't cause airway compromise, but if it compromises the airway, patient will lose the airways rapidly. Okay. So cervical spine surgery also high risk for neck hematoma. It commonly occurs after 36 hours of surgery. The risk factors include more than 3 vertebrae exposed and blood loss more than 300 ml, commonly C2, C3, C4 surgeries. And if it is operating time more than 6 hours, 5 hours, it will cause high risk of hematoma formation. But if you think it's a difficult airway or myelopathy or spinal cord injury or pulmonary problems, smoking, will cause risk factors, but usually they are not. Common factors, surgical factors, prolonged surgery, more vertebrae exposure, and more bleeding, and more prolonged surgeries will cause hematoma. Then carotid endarterectomy, incidence of post-operative hematoma 1.4%. In that case, first thing you have to do is decompression of the airway before going for the intubation. So surgical teams better persons to remove the sutures and evacuate the hematoma. If patient is talking and awake, then better go ahead with the fiber optic awake intubation rather than direct laryngoscopy. So thyroidectomy and parathyroidectomy is very rare post-surgical bleeding, but if it occurs, it will result in hypoxia and cardiorespiratory arrest within 2 minutes. I have one experience. Within seconds, patient will go into arrest, and you can't do anything. So first, remove the sutures and evacuate the hematoma. Then most of the people will get up spontaneous breathing and recover. Or remove the hematoma and then go for intubation. What usually occurs in thyroid bleeding is the hematoma is compresses the mucosa and it reduces the venous return, then it will cause edema and quite difficult intubation. Okay. So I have a compression to hematoma, always try for awake intubation, abdominal bronchoscopy or laryngoscopies. Surgical airway should be prepared always, staging should be there. And opening the wound may be considered, and spontaneous ventilation on anesthesia is preferred on induction. And always put the tracheostomy tube below the level of obstruction, otherwise it will cause mucosal edema and obstruct the airway. And due to edema, the supraglottic airways are not recommended. And video laryngoscopy is recommended, or flexible fiber-optic bronchoscopes are recommended. So second case is the angioedema. It's 64-year-old, specifically African-American population women with past medical history of type 2 diabetes, hypertension, and diastolic congestive heart failure on beta blockers and AC inhibitors. Undergoes non-diagnostic explored laparotomy often surveillance of functional and subject to dyspnea. So you all know it's due to angioedema. Its clinical manifestation usually subcutaneous and submucosal tissue edema, vasodilatation, vascular permeability. There are 2 pathologies. One is histamine-related and one is bradykinin-related angioedema. So symptoms and signs depends on which mechanism causes angioedema. Usually urticaria, without pruritus, commonly due to histamine release, and swelling of face, tongue, larynx, swelling of extremities, urogenital tract, abdominal pain, usually due to bradykinin pathway. So angioedema, histamine mediated and bradykinin mediated. Histamine mediated is hypersensitive reaction, and bradykinin mediated issues due to activation of coagulation cascade and tubular pathway. management, clinical evaluation of airway patency and initiation of standard of airway obstruction therapy. Evaluation of triggers and personal continuity and laboratory data once airway is secured. The common population develops angioedema is Afro-American population and older females. So, angioedema management, preventive measures, pre-exposure, pre-procedural assessment, and assessment and staging, then medical therapy for angioedema and secure the airway. You can manage medically initially with epinephrine and tissue receptor blockers, systemic steroids. With this bradykinin pathway, you can try the plasma drugs, even inhibitors, or the Ramanan inhibitors. If there is an airways compromise, you have to go for airway management. So, decision for approach to emergency surgical airway indications is quite difficult decision to make. Most of the physicians are not familiar with surgical airways. So, if it is in doubt, if you can't intubate, can't ventilate condition, you have to go for surgical airways. So, before that, you have to recognize early that airways are obstructed and quick assessment of melanotic classification, modify LC scoring system regarding laryngoscopy, and it may be associated with significant morbidity and mortality, and you need to have a multidisciplinary approach for that. So management of difficult airway, two options: difficult airway recognized and difficult unrecognized difficult airways. Difficult airways, anticipate difficult airways, if patient spontaneous breathing, prepare, call for assistance. Go ahead with the rate, flexible fiber optic intubation, and direct laryngoscopy. Phase early consultation with surgical team. So unanticipated difficult airway, uncooperative patient, go for sedation, muscle relaxant care, and manual mask ventilation, direct laryngoscope intubation phase, go for surgical airway. So you all know as an anatomy of upper airway, there's a thyroid cartilage, below that cricoid cartilage, in between that cricothyroid membrane is a suitable site for emergency airways. Cricothyroid membrane is around 1 centimeter width and 2 to 3 centimeter length. So you can feel it in between the cricoid and thyroid cartilage. So needle cricothyroidectomy, inserting a needle through the cricothyroid membrane to provide oxygen to 30 to 40 minutes. Percutaneous transtracheal insertion of needle, and you can give high flow oxygen to maintain the oxygenation in difficult areas. Second thing, surgical cricothyroidectomy is by making a skin incision in the cricothyroid membrane, vertical skin incision, put a scar, rotate it, or by blunt handle, you can dilate and put a small type or small 6 or 5.5 tube in, and you can go for ventilation. And all the surgical emergencies have consequences in upper airway management. So initial phase we have to stabilize, and then we have to go for definite airway. Surgical cricothyroidectomy is also recommended below 12 years in pediatric populations due to anatomical issues. Any questions? The summary, the tracheostomy tube discharge or declination occurs with diagnosis and immediate action needed. If it is below less than 7 days, let it go for endotracheal intubation. If it is more than 7 days, we can try tracheostomy tube change. Or if phase decaf tracheostomy, go for back mask ventilation with the surgeon's opinion to reinsert the tube. Second, post-operative neck hematoma. Neck patient should be reopened immediately and evacuated and go for airway maintenance to get an intubation. So angioedema is another airway emergencies, surgeries of perioperative patients, and they need medical management if it's not obstructed. If it's obstructed, we have to go for intubation and maintenance of airway. And timely decision for cricothyroidectomy and needle cricothyroidectomy and surgical emergencies like can't intubate, can't ventilate state. It's quite difficult decision to take, but to safeguard life, you have to go ahead with the surgical errors. Any questions? I'm not a good lecturer. Any doubts I can clear it.